Let me start by introducing myself. And I'm your host for this evening. My name is Harika Sachdev. I've been a caregiver for the last so many years. It started when I was 27, when um, we're just trying to figure out. There's a moment's glitch. Maybe can you all hear me? All right. Okay. All good. All good. Thank you. So we were starting the Ask Me Anything today, and me, Harika, I'm the host today for the session. I was talking a little bit about myself and telling you that I have been a family caregiver since the age of 27. It actually began when my mom started her or moved towards her end of life journey with a fatal degenerative neurological condition called CJD, and then most recently with my father, who we lost 2 months ago. In my other avatar, I'm a practicing life coach and a caregiver coach working closely with Caregiver Sathi. So let me begin by extending a warm welcome to all our listeners this evening on behalf of Caregiver Sathi. As you're aware, recently we launched this interactive series called Ask Me Anything. Here we talk to specialists to address day to day questions or challenges you go through as a caregiver real time. This is a monthly live session covering a range of topics on medical health conditions like dementia, like cancer, mental health, illness, autism, and so on. And also specialized care like palliative care, which we're going to be talking about today, and varied other caregiver related concerns that we're riddled with. So we urge you to type out your questions on whichever platform you're on for it to be answered here live. And now, most importantly, let me introduce you to our specialist today, Dr. Rajam.
Thank you so much.
Dr. Rajam is a pulmonologist and a palliative care physician with Bhatia and Hinduja Hospitals. She has completed MRCP, DNB, MD, and has been a practicing pulmonologist for 25 years. Her aim is to provide good quality healthcare in a compassionate manner. She believes that educating the patient and their family is the key to improving healthcare in India. A warm welcome. So wonderful to have you here, Dr. Rajam.
Thank you so much. Thank you for giving me this opportunity to be on this platform. And lovely meeting you, Harika. At some point, we should have a private chat.
Absolutely. Would really look forward to that. So, is there anything that you'd like to say or share before we start with the interaction?
To First of all, I think the whole country and Indians all over the world will be gearing up for the festivities next week, and it is a busy time for families. And I think my heart goes out to those who are not well or in hospitals and suffering, and for all those caregivers who have been and continue to handhold themselves, their families, and their loved ones through such difficult, rough times for yet another year. So I think best wishes to all of you for this festival period next week, and I hope it is peaceful, joyful, and bright for all of us. And we hope that we help each other, continue to support each other, and be there for each other all the time.
Thank you. Thank you for that lovely message. And yes, may the festivities be supportive, peaceful, and healthy for all. So let me open the discussion with the most fundamental question, Dr. Rajam. Uh, what is palliative care?
So I think palliative care as a name, has not had very positive vibes from people. It doesn't have a good response from doctors, patients, and caregivers. But by definition, palliative care addresses health-related suffering. Palliative care gives, the audio okay?
So it's okay. If it does start to get dodgy, I'll let you know. It's okay
Okay.
for now.
Great. So basically, palliative care addresses health related suffering for both the patients and the caregivers during the journey of any illness. And I think we should not even be saying chronic illness anymore as it was defined, because we saw in COVID how acutely people deteriorated, and palliative care really played a very important role. So it is that aspect of medicine that I think every doctor needs to be trained in, and each doctor needs to know when to switch on to his palliative care hat, because we are here to care. We are health care professionals, and somewhere along the journey, we have forgotten the word care and we continue to focus on the word cure. And it has become such a business like transactional relationship between a patient and a doctor that we forget the emotions, the sensitivities that goes on when a patient sits across the table. One realizes that when one becomes a patient and sits across the table from a doctor, and really hopes you're dealt with compassion and kindness.
I think that's so pertinent, both, when you're interacting with the patient as well as with the caregiver. Because when the question of, like you rightly said, it doesn't have to be always terminal now. There is, even if you're suffering from any end of life journey, or suddenly things start to deteriorate, and from a caregiver's point of view, the compassion is so much needed, because there is this constant sense of guilt that a caregiver has, and doesn't know how much more, how to, and where to do what one needs to do. So thank you for that. I also wanted to check or ask you, what is, there is often a confusion about hospice and palliative. So what is the difference, and is there any difference?
So, to be honest with you, hospice is a place,
Hmm.
not a hospital, where there are active, curative, or life sustaining treatments done. Hospice is a place where people are admitted so that they can be kept comfortable and essentially see to it that they transition in peace. So, a lot of countries where hospice is a part of insurance, like America, etc., there, because it's a part of insurance, people are admitted so till they are actively dying and towards end of life. However, in places like Europe, in England, where the government pays for your medical expenses, specific people towards end of life are only admitted in hospices, because you do not have the capability of admitting large number of people for a long period of time. Now, in India, the concept of hospice is still not there for many reasons, because the social fabric of this country is different. The family unit of this country is different. There are people to look after. For example, children give up their jobs, change their life, change their life so that they can look after the loved one, or people are rich enough and labor not being so expensive can afford to have hired help at home to look after the loved ones. And there somehow is still a mind block, even amongst educated people, that going to a place like a nursing home or a hospice for an elderly to die is like abandoning the elderly. So I think multiple causes are the reasons, and plus, of course, real estate in big cities where hospices becomes difficult, and therefore you see most of the places where there is a retired community or an old age communities out of the main city, middle of nowhere, where then medical facility becomes a challenge. So I think we should realize the difference. Of course, the social fabric of India is also changing dramatically, because most children live abroad. There are a lot of elderly who live alone, and therefore maybe it is time for us to rethink about the need for hospice, where our elderly can still die pain free and with dignity and respect that everyone deserves at the end of life.
Yeah, absolutely. But I think we probably still have a long way to go, though the dialogue has started, and I think that's important. Even just, although we are talking palliative and hospice, even for assisted living, just like what you're saying, uh,
Yes.
everybody wants to, when they talk about it, you're always worried about the feeling of being abandoned, and that's a cultural change that hopefully we'll be able to bring. My next question to you is, who can provide palliative care?
So the beauty of palliative care is the multidisciplinary team. Doctor is just one person in the whole team. I think what happens is the communication between patients and doctors is intimidated because patients are scared to ask questions, doctors are busy, doctors do not seem to have the time to talk to patients especially patients who have the need of hand holding and who have a lot of questions and queries. Somehow there is a gap between what the doctor can give and what the patient actually needs, and that gap is actually beautifully filled by nurses, physiotherapists, counselors, volunteers, social workers, and also, like you mentioned in your introductory talk, people like you who have been hands on caregivers. If you talk to another patient who's gone through, say, what your parents went through, you have hands on experience that, this can happen or that can happen. And that's a big platform for the caregivers to actually share notes. So, palliative care can be given by everybody. You just need to have a compassionate, kind human being who's sensitive to the needs of the person. And, even if the caregiver is supported well, he looks after himself better and he's in a better frame of mind to offer caregiving. Because modern medicine today does has increased the lifespan. People are living longer but not necessarily living well, and that's the reason why caregiving can go on into years. And even the caregiver can suddenly become a senior citizen and still continue to do the role of caregiving for his elderly mother or father. And then you realize that his or her life has definitely been somewhere short shell, because he's all his life he's done only caregiving. So everybody needs a break. You live only once, and therefore we really need to support the patient as well as the caregiver, and not reach a point where both feel they're a burden to each other. So that the environment in the house, the atmosphere in the house can be something which is of, share a peace, joy, and giving and taking love.
That's right. Yeah. And one other thing came to my mind just like when you were sharing that uh, people who have been caregivers and then, because of our Indian framework, may have given up working or their lives. Once they have, their journey as a family caregiver perhaps comes to an end, they provide this wonderful support system. And also, it is a sense of, in some ways, validation for them, because I think self-worth has suffered so much for caregivers on that journey. It's been a one-way street for a large, and I sometimes, I also I resonate with that. So it's good to have this opportunity and a community to access caregiving and palliative care support. And thank you for bringing that up so well. um, I also want to understand what are the benefits of palliative care. And would a doctor recommend this upfront? I know you touched on it slightly, but because you don't know, and sometimes you feel it's better if the doctor were to suggest it.
Right. So, unfortunately, when I got trained, and for many years before me, we are not trained in India uh, to to talk to patients. So there is no communication class for doctors in the 5.5 years of MBBS or in the post graduation. Point number two, we are not taught to talk about death and dying. So this is something is brushed under the carpet, even in a profession which is closely linked with sick people, and which wherein we see people dying every single day. I remember when I first saw death, I didn't know how to cope with it at 18. So it's a very tender age where you have this is going to happen, but nobody kinds of teaches you how to cope or how to see the relatives. I used to avoid looking at relatives when they were told that their loved one has died. So we it is unfortunately a big lacuna in our training, which has now been looked at from September 2019. Undergraduates in MBBS are trained in attitude, ethics, and communication skills. So the problem is the doctors who have graduated before that, they really don't have the concept of this. The second thing is, you asked me about I mean, where can you said where it can be given, that I told you. The second and the most important thing, therefore, doctors don't realize when to actually start referring patients to palliative care, and they don't realize the need till they become the recipients of palliative care. For example, people like me. So a private loss, the loss of my father is what made me think as to how non-medical families will struggle with any chronic or any acute illness, because the only thing that doc families can think is rush to the ICU. whether the patient is 18 or whether the patient is 90. They can't see their loved ones suffer, and out of love and care they rush to the hospital, and the hospital treats 19-year-olds and 90-year-olds in the same way. It's like a conveyor belt. It's casualty, intensive care, ventilator, advanced medical treatments, and things keep going on. It is much easier for corporate hospitals consultants to do aggressive treatment rather than spend the couple of hours talking to relatives about the futility of prolonging life sustaining treatments. Also, nobody talks to their elders when they are fine. For example, you and me will appreciate learning to swim when the sea is calm, not in a storm. Your elderly has become 80 and 90 over 80 and 90 years. It is important for us, especially when there is a family GP or a doctor in the house, to ask your elderly how he or she would like to be treated in an emergency. Because if the elderly is very clear, I don't want to go to hospital, मुझे घर में ही रहना है, हाथ पैर चलते हुए ही जाना है, या मुझे comfortable रखना, we need to respect their wishes. And this is the first pillar of medical ethics, which is medical autonomy. We never ask people, what would you like to do? It is always when the doctor says, according to me, in my experience, you should do this. But what is good for me may not be good for you. So we need to explain to the patients, give them the information so that they can process and analyze and say, yes, this is good for me. Sorry, I don't want to go through it. So autonomy is important, which is medical ethics. The second thing is, whatever we dish out to patients as part of prescription, is it in the patient's best interest? We forget that. The Hippocratic Oath says, do things in the patient's best interest. We have now implemented that as in the best interest of the patient is forgotten. So we need to focus and bring back our medical treatment to do something to the patient's benefit and do no harm. The last pillar of medical ethics before I hand over to you, Harika, is justice. And that's what we saw during the pandemic. We had 10 beds, 6 ventilators, and 40 patients. How do we decide which patient goes on the ventilator? So, if people had made up their minds, from the West, we had enough evidence to suggest that elderly people did poorly on the ventilator and aggressive treatment. Those are the patients we should have had triaged, talked to them about comfort care, kept them comfortable at home or ward, and not got to the ICU. Unfortunately, the rich who were able to spend that money got the ventilators, and the 40 and the 50-year-olds did die because there was no concept of palliative care. There's no concept of justice, which is the important part of medical ethics. So all of these comes into play. We realize we need to deliver ethical medical practice to the patients, and that really does make a difference.
I think you're very right, and thank you for sharing that or shedding light on that from a medical practitioner's point of view. I'm going to take this a step further and actually ask you that, as a family caregiver, what do I need to do to plan for palliative care of my loved one? Maybe I can take that first step. I mean, whether it's emotionally or financially, and also what is it that I should really be prepared for, or maybe even wary of?
I think the first important thing as a family caregiver, if you have an elderly at home or if you have a loved one who has a chronic illness with no cure or progressive, is to talk. Communication is the most important thing. Whether the person would like to know more about his illness, whether what the person would like to do in an emergency, please let me know what your wishes are, where you would like to be treated. Would you like to go to the ICU? Would you like to be on a ventilator? So, communication is very, very important. Advanced medical directives, which is popular in the West, is now allowed by the Supreme Court. So, we need to learn to talk. And the Indian Association of Palliative Care on its website has a draft of a living will. We are all happy to talk about financial wills.
Yes.
This estate goes to my son, this goes to my daughter. You need to know what we need to do with you in an emergency, because the person who endures it has no capacity to decide at that stage. So we really need to decide much before, so that things are in plan. And what you mentioned, the guilt therefore there goes out of the window, because the person himself has decided. what he or she wants. So once the person has decided what you want, at least the children can be guilt free. My father wants this, my mother doesn't want this. Let's stick to that. We have a plan. So, first and foremost is to talk to your elders, communicate. It really makes a difference. Then, of course, comes the challenge. However prepared you are, Harika, it's very difficult to lose a loved one. So obviously, caregivers also need that support emotionally, psychologically, the counseling, whether there is enough money to look after the loved one. Those things do come. First thing is, of course, medically, if you're sorted of how much you want to do and where you want to treat your loved one.
Okay, so there is a question from the audience where Ria is asking that can I continue the primary doctor's treatment along with palliative care? And there's a related question I just put there also. What all does palliative care involve?
Okay. So basically, the idea with palliative care physicians, the dream we have is to integrate palliative care with curative care across specialties, be it neurology for dementia, Parkinson's, motor neuron, etc., renal failure, cardiac failure, chronic advanced lung diseases, cancer. So the whole idea is to integrate. Now, that integration will come only if the medical fraternity is aware of the benefits of palliative care. So, yes, the earlier the integration, the better it is, because even if we are not able to change the outcome, we are there as a support during the difficult journey to make the journey bearable, to be as a friend, a mentor, a guide for the patient and the caregivers. So, you need a doctor who's open to palliative care and therefore start palliative care along with curative care, introduce the palliative care team at that time. So we also form a rapport with the patients, and we do difficult dialogues with the patients, and it's very difficult to enter towards end of life and say, would you like ICU, would you like ventilator? But if we have been there for 5 or 6 months before, understood the patient understands us, familiar face, then these conversations become a bit easier. So, yes, you need a cooperative primary care consultant, and we like that because the primary care consultant can look after the primary illness and we do all the hand holding. So, he's not like, oh God, too many questions from this relative. So, those things can be avoided by integrating palliative care. Quality of healthcare improves and the patient's care experiences improve. So, this is what palliative care entails. It is basically a holistic look and a holistic support for patients and caregivers addressing the health related suffering, which is not just physical, it's emotional, psychological, financial, spiritual. And we are there to plan this journey for the patient, prepare the patient's family, and once the patient passes on, include the bereavement phase so that we address complicated grief or difficult grief for relatives, because sometimes it can be really difficult for a child to lose a mother or a mother to lose a child. It's been the COVID has taught us how complicated things can be of losing multiple in the family. So this is all that palliative care entails because it is a multidisciplinary team. It's not just a doctor.
So, a related question, sometimes when the primary caregiving doctor would say that there is hope, and how does that really get balanced? Because the family, the patient, and the caregiver, they're all in any case struggling. And we talked about this whole feeling of guilt. So, how does the patient or the caregiver convince themselves that, maybe you shouldn't go for surgery or the ICU and it's time to now either move back home or happens there, because that's a constant conflict.
So this is where the medical training comes in phase, where we keep telling ourselves that we need to give patients realistic hope. See, उम्मीद से चलती है दुनिया, but that doesn't mean we give the patient unrealistic hope. So there's a stage 4 cancer, it's spread everywhere. You still say, okay, let's try immunotherapy, let's try this. This has also come, that has also come. But we therefore need to train our patients and caregivers to ask the right questions. For example, what if I don't do this? What are the chances of survival? And unfortunately, we focus on quantity of life. We very rarely focus, including doctors, quality of life. If you see research papers in medical journals, it is survival which is one of the endpoints, but nobody realizes how does it translate to the well-being of the patient and the caregiving. Yes, patient is alive, but is he living well? These are not the two same things. So we really need to train our doctors to give realistic hope and our patients to ask the relevant questions. what doctor, if I decide not to do this, what will my life be? Because, Harika, one thing I really think we doctors are very smart in avoiding. We have seen many patients of cancer. We have seen dementia. We have seen 100 patients of advanced lung disease. The onus is on us, right? For that particular family, it is one patient who is the dementia patient or the cancer patient. But I have seen hundreds such. I know the trajectory that if the patient is this, if he has so many comorbidities, he's been to the hospital so many times, it's not looking good. So it's my onus to foresee and foretell. So it is the onus of the medical practitioners to actually say that I don't think, in my opinion, this will work because of one, two, three, four. That conversation has to happen, and we really need set of compassionate, encouraging doctors. But unfortunately, our system is such, because 80% pay out of pocket. More you see, more you do, more you earn. And corporate hospitals also have targets. So unfortunately, the patients get caught up in this system, and it really is proof. That's the reason why I feel that faith and trust in doctors is at all time low. And I also have this hope that once you hit rock bottom, the only place to go is up. So hopefully, because of palliative care and because of people like you and Bhavna for Caregiver Sati, I think we hope to get in a revolution where by the time I need palliative care, I will have a doctor who can give me palliative care, because it really needs to be a movement. There has to be a paradigm shift in the thought process of not just medical fraternity, patients and caregivers. We need to start having patients who ask for palliative care. I want comfort, I want dignity, I want respect. I don't want to endure if it is going to only prolong my life and prolong my poor quality life. So there's a huge role and responsibility from the society also.
So you said you touched a really important point here when you said that I can ask as a patient. I want to take that a little further and ask you, what are the decisions really that the patient is allowed to make here in palliative care?
Sorry, what are the decisions you're allowed to? Everything. Whether you want chemo, whether you want surgery, whether you want to go to hospital, whether you want to go to ICU, whether you want to be put on ventilator, whether you want to be resuscitated, all these questions are asked and documented. So you have that. It is your body, it is your decision, it is your right. You have to be given that right to choose what option you want. Having said that, the onus of the doctor is to explain in the language that the patient understands so that he makes the correct decisions. He needs information to make the decision, and that information has to come from a reliable, trustworthy medical source and not Google and not the internet. You have to have that conversation that if you do this, there is this percent chance. If you don't do this, there is this percent chance. Most important, we need to focus on the quality of life. That is very, very important, because we in India are Sada Ayushman Bhava. This Sada Ayushman Bhava focuses on quantity of life. And somewhere we need to bring quality, where another Sanskrit shloka which I have heard growing up is Anayasena Maranam Vina Dainyena Jivanam. That is what we want to hope, that we die in peace and not suffer with disease. So it's very, very important that the suffering is addressed, and that is something nobody budgets for. And that is what palliative care wants to address, is the suffering. I mean, I can't change everything. I don't have a magical wand, but I address it, I acknowledge it, and I tell the patient and the caregivers, I can see it is distress. Let me help you. At least let me support you. Let me be your friend through this journey.
uh, my last question to you is that a lot of times family caregivers and even patients themselves say that if you're going in for palliative care, in some way they are giving up. How do we explain that it's not really giving up? Is there something that can be said?
So I have faced this all the time. And I remember when I spoke to this to Dr. Rajagopal, who is the chairman of Pallium India and who's known to be the father of palliative care in this country. He said, Rajam, every new idea will be first laughed at, then ignored, fought, and then accepted. And today also I feel, and even he thinks so, that you can, keep you constantly be in this thing of being ignored and laughed at, unless we have the training of palliative care for doctors from the beginning. It will always be thought of as giving up, because also corporate hospitals, the joke is that the rich cannot come out and the poor cannot go in. So, constantly the need to do things, and somehow they feel letting go is equal to giving up, while letting go is aligned with the patient's wishes, patient's desires, and also very, very important to give the respect and the dignity that every human being deserves, irrespective whether they can afford the medical treatment or not. And which is why I feel that in this country, all across the socio-economic, the lower middle class, the middle class, and the rich, when they die in agony. The rich on the ventilator, the middle class in ignorance, and the poor people with neglect. And that is what we need to change. Just because he's an ABC and he can afford money, he shouldn't be suffering. And just because he's not rich, also he shouldn't be suffering. So, somewhere we need to bring that justice, and we need to realize doctors need to be sensitive to the suffering of losing a loved one. It's not just physical. Even if it's a 100-year-old grandmother, you have the emotions, you have the bond, and that person is gone forever, because bereavement is permanent and grief is forever. We really need to focus on that, and we are not trained to realize that.
Absolutely. I have one other question, more from a caregiver's point of view. There is always, and we are trying to get caregivers to join and to support them in support groups, but we always get this from them that as a caregiver, my hands are already full. I don't want to join another support group. What can you say to them? And I will say from my own personal experience also, Dr. Rajam, before you say this, that just being part of a community is so energizing and reassuring. Even to pick up the phone or send a message to somebody in that community is, it just, it tells you you're not alone and you're not abandoned. So that's my personal experience, but of course I'd like you to share as well.
So yes, even as a caregiver, I've realized that when you're told to join support groups or attend a meeting at a particular time, probably that's the time you're just wanting to doze off. It is not easy. But I think the way to get around that is ask that particular caregiver, okay, tell us what your issues are. Suppose he says, that's the time my child comes from school, or so we can tailor make it saying, okay, once a week we try and change the timing, or we say, what time does your maid come, or do you have somebody to relieve you, or can you ask somebody else to sit. And we can, if we tell that the benefits of the me time for the caregiver, then maybe even if not immediately, it takes a bit of time, to get off. You want to look presentable if it's a video call, or so there are so many things, aspects. Probably the person hasn't slept for 2 nights, or he's so overwhelmed, torn between his family, being the caregiver. So I think most important thing is to just talk. I think talking is something, and communicating is so important. Saying, okay, I appreciate you want to come, you have issues, tell us your issues. If we can sort it out, will you come? I have benefited from it. Why don't you try once? Maybe coming once, you'll see. If it doesn't benefit you, you don't come. Things like that. So I think it helps. And I think what we forget is, unless a person is 100% fit medically, emotionally, he or she cannot look after anybody else. And the worst thing is, your frustrations, your irritation comes out on the patient. And then you feel bad about it, that you were rude to your mom or you snapped at your dad. And so, these things, only if you've been through the journey, you realize. So maybe you could share your own personal experiences by saying, maybe, get out, get onto this show. Maybe you have another person who does the same thing, then you don't feel all that bad. Or go for a walk. If you don't want to come to a support group, at least take care of your health. Sleep early today, go out for a meal with a best friend, something else to where you can vent out and get your frustrations out, so that you can come back as a rejuvenated caregiver. So I think everything can be solved by a conversation, and you just need a sensitive, kind, generous person, generous with time at the other end of the phone, or of the corridor, or whatever. So it's great to have such a platform where caregivers also can find friends and not be alone in their difficult journey.
Absolutely. I think that point about just keeping the dialogue or the communication open, and maybe letting the caregiver know that we are there in case, and just some small nudging reminders that self-care is so important, because unless you take care of yourself to whatever degree you can possibly, you'll probably not be able to show up in the way that you want for your patient or the person you're taking care of.
For example, Harika, you and me both have been family caregivers. And what is important for you to, when you sometimes just sitting and some friend sends you a message saying, how was your day? Even if you want to cry, if you've had a bad day, but the fact that at 10 in the night, this person has taken the time or the effort, it means a lot. And I really think that helps, even if you don't reply or send one emoji. But at least the fact that somebody miles across is thinking about you and praying that you have had a good day, or at least happy to share if you've not had a good day. I think it
Yeah,
makes a big difference, doesn't it?
that it does. It really does. Um, let's get back to the communication with the palliative care team. Is there something that I need to be able to say to the palliative care team, or do I need to hold back? Could you maybe talk a little bit about that? Or do I expect my primary doctor? We addressed it shortly, but my primary doctor to take that responsibility. Sometimes I don't want to communicate everything.
I think the communication is best if it is total from to the palliative care team and to your doctor. So this is what I said. I think very often patients and families are intimidated to talk to their doctors. I think if you do not have a doctor who encourages conversation, that doctor needn't be your doctor. Very often I say, when I tell patients, and patients tell me, but वो डॉक्टर के पास ना 3 महीने के बाद अपॉइंटमेंट है, 2 महीने के बाद अपॉइंटमेंट है. I said उतना देर, you cannot eat yourself within with worry. You really need to get to a doctor who can sit and talk. And to be honest with you, like I always quote this example, not everybody in cricket can be Sachin Tendulkar. Not all the doctors are the best, but you just sit back and think which doctors succeed are the ones who communicate, especially to the ones who are needy. So all your 10 patients are not going to be with the equal level of need. So a doctor becomes successful if he identifies with his sensitivity which patient needs more hand holding and which patients can be said, look, I'll come back to you later, and the patient will be quiet. So I think the doctor who gets the time to the right patient at the right time with unhurried conversations, sensitive conversations, a little pat on the shoulder, or a little extra time with that patient, and that makes a difference. We do have good doctors in this country. We do have excellent clinicians, but it needs to be translated with good communication. It Communication is like a procedure. That's why palliative care is also called narrative medicine. You need to be able to dissect all those jalis and thoughts and all those negative things in the patient's mind and let him arrive at his own conclusion. Doctors can only suggest. Doctors cannot and should not decide for the patients. But the onus of the doctor is to explain the stuff. The onus of the doctor is to foresee and foretell that I don't think this is going to be the wise way. The decision has to be the patients and the family, and the doctor should support whatever decision that patient takes, because to each his own. Cannot be कि मैंने बोला था ना क्यों किया. That is the language that we talk.
Yeah.
I had told you so. The point is, it is for the patient to decide, and we need to support the patient in whatever decision he takes.
True, true. And sometimes, like you rightly pointed out, if you are feeling that your primary doctor is in some way not able to have the kind of dialogue that you want, maybe that's where the caregiving support groups can come in, and we can, at least you can talk to them about a situation like that, and it's a roadblock that you're hitting, and maybe take that dialogue further with possibly another doctor or a palliative care team to help in this journey.
True.
So
Also, second opinion. See, this is another big thing that families feel scared to do. But it is the right of a family to get a second opinion. And it is not an ego battle here. It is the question of somebody's life in totality. So, second opinion should be welcome, and it should not be like a threat to the doctor, because every day is a learning day for each of us. We need to learn something new every day and learn to approach. See, a doctor also can have a bad day, right? So maybe he or she missed out on something. And the second opinion can make a difference. And especially if it makes a difference in a patient's life, it is the best thing for a doctor. You feel so satisfied if you made the difference even in one life.
that's right. Yeah, yeah, yeah. That's a wonderful tip, and to keep a second opinion in mind. We've mostly addressed, Dr. Rajam, palliative care for elderly patients in our conversation today. I do want to ask you that how does it differ for children? Is there a difference in palliative care for children?
I think, see, I'm not experienced in dealing with children, and I think it can be excruciatingly difficult branch. Though the team in Vardia, which is one team in Mumbai, who has started pediatric palliative care units and also home visits, are doing a remarkable job. But I can understand the trauma because it's not just one, but it's two see elderly involved to convince about how sick their child is. So the approach is different. When you talk of giving up, people are not ready to give up 90-year-olds and 100-year-olds. Imagine a 9-year-old and a 9-month-old. It must be really, really tough. So pediatric palliative care is the principles and ethos is the same, but I think the skill set is very different of how to handhold this very delicate journey, because it's must I think one of the most challenging things is to bury your own child, and that can be really, really difficult for parents, and it therefore equally challenging for pediatric palliative care units.
Yes, that is true. But it's good to know, reassuring that there are places that one can at least approach for pediatric palliative care. Um, I want to ask you another question related to symptoms. Sometimes symptoms get worse, and in some ways, if we have a palliative care team working with us, they prepare us for that. Does it also happen that the symptoms could get better? And what happens?
Yes, surely. In fact, recently we discharged a 92-year-old gentleman from a private hospital in Mumbai. And actually, we didn't think he had that, because the way he progressed in the hospital, the relatives were very keen. They didn't want all the poking and the prodding. And we didn't think he would last much at home. But actually, he improved, and he's asking for food. He's sitting up. So when the acute thing passes off, yes, we can expect the symptoms to improve. And that is what also sorry, research has shown that integrating palliative care not only improves the quality, patients live a bit longer and better. So the quality of life improves and even the quantity. So this research was done in lung cancer patients. It's a famous study quoted as a Tamil study, which was published in 2010, which shows that patients who had palliative care support lived 3 months longer than patients who didn't, much happier, and died where they wanted to in the preferred place of death when they were all in the same stage of cancer. So it definitely improves. Research has proved how it improves. And I think the health seeking behavior, utilization of health resources, unnecessary avoidance of hospitalization, caregiver burden, compassion fatigue, all that was addressed. So end, net, it's a win win for all.
It's very
And it
holistic.
definitely has made a difference. Yeah.
Yeah, yeah, yeah. Okay, and on the other side, if the symptoms were to get worse, how there is, it's not always talked about very openly, but I'd like to address it. That how can we get painkillers or maybe morphine in the case of high pain, and are there legalities involved there?
So see, morphine is a narcotic, and it comes in the list of essential narcotic drugs. And there has been a change in the Narcotic and Psychotropic Drug Substances Act in 2014. So hospitals can register as a registered medical institute and get the license to stock morphine. So most people are unaware of this, that they can stock morphine. Two, if you have a palliative care team, all of them are trained to use morphine, to prescribe morphine, and they will also be able to, in certain parts of the country, like Kerala, they dispense morphine at home.
All right.
So
Okay.
they carry all this in their home care team van, and they dispense all the essential medications. In Bombay, there are a few chemists that stock morphine, and usually we give the prescriptions in triplicate, so that we also do something called as anticipatory prescription. We expect this patient to have 1, 2, 3, 4. For example, vomiting, hallucinations, pain, and we give the family these medications, and we train the family physician that if this happens, give this, so that all the medicines are stocked, and morphine is one of them. Yes, it is not easy to get morphine across the country and in every little town and village, but that is the reason why, if we integrate palliative care and that team evaluates, then you can give an anticipatory prescription, and patients can be prepared for an eventuality, and caregivers are taught and empowered of how to treat which symptom and how and when.
So where do I get more information? I mean, I know that palliative care is important for me. I am based say in a northern state in India, and there is not that much dialogue about it. So, is there information that is readily available, and where should I access it?
So, Indian Association of Palliative Care, which is IAPC website, has details of where palliative care centers are there across the country. If you also search for certain topics that Dr. Rajgopal has put up on YouTube, MR Rajgopal, and of course, if you now search for Mumbai Palliative Care Network, there are a lot of YouTube videos, recordings. And another thing I would like encourage everybody to read is Atul Gawande's Being Mortal. It
Yeah.
really is a good book which starts your thinking process of what to do next. And there's another lady called Catherine Mannix who has written a book of what really matters in the end. And she writes very well. I really like these two books as a beginning for people to be aware of their rights and aware of being asking for palliative care, asking for comfort, dignity, and respect. And it's a great start for a conversation with your family GPs.
uh, I think that's a wonderful sort of input. And in any case, I also want to let our listeners know that we do have a lot of this and other resources on the Caregiver Sati website as well. And we're happy to have your questions related to this and maybe direct them to the teams that can support and assist in that. Thank you so much, Dr. Rajam. It was a really shed light on so many aspects that we don't talk about. We think, and they just are inside us. We just bury them. The dialogue, like you said, is the most important. Once the conversation starts, a lot of things come out. And when we ask questions, it's not only our own answers that we are getting, but we're helping a lot of others get their answers, those who don't have access to having this conversation. uh,
True.
so, so thank you for having in some ways a rather enlightening talk on palliative care today. uh, Always wonderful to read and hear. I've heard a lot of what you have said on YouTube and other video recordings, so it was wonderful to meet you today.
Entirely my pleasure. Even though I met you first time virtually, I really hope to see you in person. And
Likewise.
I always feel that this is the country where Bhagavad Gita is kind of read and revered. And Bhagavad Gita also tells you how to detach, how to let go, and how life and death is the same side of a coin. I all strongly feel that death is inevitable, but a bad death is avoidable, and that can only happen in conversations. So it's very, very important to keep this conversation and continue to encourage people to talk, even if you can't find solutions. But I think the fact that people listen to themselves can get them answers too. So I think very, very important to make people talk, be there, listen to people, and help them in whatever way we can, because that's the least we can do. And I think COVID has taught that the least we can do is be really fiercely kind and compassionate to each other. So
Yeah.
thank you so much for having me over. Thank you.
Thank you. Thank you so much.
Thank
Uh, to all our listeners and family caregivers, I want to say to you that if you are looking for a community or curated information, any learning programs, coaching or emotional support, any other services in this journey to support you, we'd really love you to register with Caregiver Sathi on our website and help us help you continue this journey in the best way possible. So thank you for joining us. It's been wonderful. Thank you, Dr. Rajam. Thank you, the entire caregiver team, caregiver Sati team. And I'm glad I was here and I'm part of this entire awakening, as we say, which is much needed in our country right now. Thank you.
Thank you. Bye bye.
Bye bye.